Thank you for inviting me to this interesting conference. My apologies for not being able to be there. I'm Jorge Pagola, stroke neurologist in Valdebron, and my talk today is about the basis of a focused echocardiography for neurologists. These are my disclosures. Well, sometimes we need to focus to find out what we are looking for. Almost 30% of strokes are related to heart diseases. Neurologists are familiar with ultrasound techniques. So therefore, neurologists must be involved in focus echo of their patients. Many position papers provided recommendations about how to focus echocardiography in different fields. But there were no experience in the stroke setting. So in 2014, we evaluated the focus echo performed by neurologists. Following our protocol, focus echo was defined as 2D color transthoracic echocardiography focused to find the main sources of emboli in left ventricle, left atria, and aortic arch. In 2014, after 1 year training, we designed a protocol in cooperation with cardiology to uncover the etiology of cryptogenic stroke. We registered the main sources according to the most prevalent stroke causes suggested by recommendations of the European Association of Echocardiography. As you can see, ventricular akinesia, complicated aortic plaques, and patent foramen ovale, PFO. Every result was reviewed by an expert cardiology to assess the validity of the focused echocardiography in neurologists' hands. So ventricular akinesia was then found as a lack of wall segment movement in concordance with the absence of wall thickening. You can see in this video, this lack of wall thickening in the apex of the left ventricle. Despite the sensitivity was enough, the specificity was not so good because the diagnosis of ventricular akinesia required experience in the detection of ischemic myocardiopathy. So we suggest using echo contrast to enhance the visualization of the apex to rule out intracardial thrombus, like here. You see a big thrombus there in the apex. This is the left ventricle, and now we are using echo contrast to see easily the left ventricle. Regarding complex aortic plaques, they were defined as a plaque more than 4 millimeter size in the aortic arch. The visualization was good. You can see a plaque right here. And the validation was good because the technique to assess the aorta is similar to the examination of carotid arteries, longitudinal plaque and coronal section. You see this thrombus, it's moving, and it's about to emboli to the brain. It's important to start a treatment ASAP. And this is the same plaque, different view in order to confirm the suspicion. Despite TEE is the gold standard test to detect the aortic plaques, the ability of the transthoracic echo to detect plaques was proven. Well, fortunately, neurologists have other techniques as aortic CT to confirm the visualization of the plaques. But in some cases, the chance to detect the plaque is not that easy, neither with the aortic CT nor a TEE, like in this case. In this case, with suprasternal window, using focus echo, we could observe this plaque, with the thrombus moving right here in the carotid artery ostium. This is not a ghost. This is not the noisy signal. The color is, you see, surrounding the plaque, and you can observe in a mode. So it's a real thrombus. In 2015, we compare our protocol to detect aortic plaques with TEE, transesophageal echo, and the sensitivity was good enough. But again, we have some false positive cases. Yeah, the sensitivity and specificity was excellent with all techniques in our hands to test the patency of the foramen ovale, for instance, as you can see in this figure. Yeah, these are my fellows and knowing patients doing in the same time focus echo and transcranial Doppler to assess a patent foramen ovale. Yeah, transthoracic echo can show us relevant information regarding PFO complexity. This video is showing us a patent foramen ovale. You can see this is the right ventricle, the left ventricle, and the microbubbles passing through this patent foramen ovale. Yeah. So with transthoracic echo, we can assess also relevant information like here. The presence of atrial septum aneurysm is quite easy to observe with 2D echocardiography. Just like here, again. Sorry about that. Here, this is the aneurysm, septum aneurysm. Okay. Also, the presence of a prominent Eustachian valve, like here, we can observe it. It's not that easy with transthoracic echo. You need some experience. But this Eustachian valve, its function, it's to redirect the flow coming from the inferior cava directly to the PFO. And that's why it's important to detect it. Another thing is a remnant called Chiari network reticula in right left atrium with prothrombotic properties. Even with focus echo, we may differentiate PFO from interauricular communication by the detection of a right atrium enlargement right here. This is a case, clear case, in interauricular communication. And it's very important to detect, as you know, in every case we detect, it should be closed. But we still miss the first cause of potential embolization here, that is covered AF. Once we have found out the main potential embolic sources, focus echo may help us to uncover patients with AF. Left atria is a classic predictor of AF development. And with focus echo, we can assess the size of the left atria easily, just like here. These are the recommendations. This is the left atrium. When the left atrium is fibrosed, its deformability is impaired, just like here. We can measure this impairment by strain analysis. That is a special echo software that use speckle tracking to assess the left atrium deformability. Yeah, Some papers, previous publications have demonstrated that this left atrial strain, this left atrial deformability is associated with paroxysmal atrial fibrillation. Indeed, it is reduced in patients with atrial fibrillation. So we demonstrated that the usefulness of this left atrial strain to uncover AF in cryptogenic strokes. This left atrial strain had more sensitivity. Its sensitivity was better than the left atrial size, and you can see in this picture. So looking at the big picture, in 2018, we evaluated 396 patients. Of those, nearly half of them had at least one of the predefined sources of a stroke. You can see it here. The most prevalent was left atrial enlargement. What was the impact of our source detection? Well, the patients that started anticoagulants were significantly higher when ventricular akinesia was detected. Similarly, those who received double antithrombotic therapy were much prevalent in patients with diagnosis of complex aortic plaque. The detection of atrial septum aneurysm was more frequent in patients with PFO detection. And the percentage of AF diagnosis was more frequent in patients with left atrial enlargement. We have an impact not only on treatment decision, but other techniques requested to detect the stroke etiology. In this figure, you can see that TEE was ordered more frequently when aortic plaques or a PFO was observed, but not in the others. And also, when ventricular akinesia was detected, full TEE was requested, but not in other cases. In 2019, we have implemented a new technology to share our images with cardiologists as soon as possible. And this is called Join. Join is a communication app designed for physicians that enables a fast connection with your PACS to share your imagings wherever. We are integrating the whole POCUS assessment, including heart, carotid vessels, and intracranial circulation in one step. With this machine, MyLab Omega from Isaote echocardiography, seems a good tool with a limited cost to do this job. Can we perform this whole scan assessment anytime, anywhere by our own smartphone? Well, we are evaluating this interesting probe called IQ Butterfly. It is easy to use and we will have data to share it soon. Well, before doing this type of studies, focus echo, cardiac focus echo, it's mandatory to have a proper education and formal practice by a certification. With our experience, we reached an agreement with our national cardiologist to certificate every neurologist willing to apply focus echo in this daily practice. Well, this is a paper about our consensus document that pointed the main recommendations and our protocol to teach neurologists and internal and GP doctors to learn this focus echo, cardiac focus echo. So, well, yeah, this is my last slide. Now we are training neurologists around the world in this technique. And of course, you are invited to come with us to Barcelona to learn how to do it. So please contact this email if you would like to learn how to do it. Thank you very much, and thank you again for having me here with you today.